شلون ما
انا راح
نسوي له ستارت ترى.
قاعد يشتي يعني. يلا تفضلي.
شاشة واضحة يعني ما في عندها فضول؟
اي ما دخل.
مساء الخير، أنا
دخل. يلا.
مساء الخير، أنا سدلاني سنة ماجستير Pharmaceutical Biotechnology and Drug Designing from Jamia Hamdard, New Delhi. Today I will going to present of lecture about the skeletal muscle relaxant and neuromuscular junction blocker agents. Table content, introduction, classification of skeletal muscle relaxant, classification common medication chart, spasmolytic agent اللي هي تحتوي على acute chronic and chronic use, mechanism of action and common side effect, and the neuromuscular blocker agent, liberalizing and non-liberalizing agent, it's for clinical use indication, and mechanism of action, adverse effect at the end, important consideration and ground. Table on our goal. First, the title in pharmacology, the skeletal muscle relaxant, and the target group it's medical student, allotted time for 30 minutes. The general goal of this lecture is about studying and for understanding the skeletal muscle relaxant, to differentiate between the two main classes of drug affecting the skeletal muscle, and also learning their primary mechanism of action and recognize their major clinical use and risk. The behavioral objective at the end of this lecture, the student will be able to list the examples of skeletal muscle relaxant and neuromuscular blocker agents, and also they explain the difference between CNS acting antispasmodic and peripheral neuromuscular blockers. Also, they can apply a consult a patient on the sedation risk and warning against combining with alcohol. Also, they can analyze, contrast the unique mechanism of dantrolene with a CNS-based agent. Also, they can evaluate, justify the short-term 2 to 3 weeks use limit for the antispasmodic muscle relaxant, and also at the end they can design a monitoring plan for the patient on dantrolene addressing hepatotoxicity risk. The active method we will use today about this lecture, a flipped class, brainstorm, a group effective discussion, homework, presentation, and also the material for training used, intelligent board, PowerPoint, Digipad, feedback, and Google site, Google form, education video. Evaluation, it's coming by the homework, feedback, and evaluation with the rubric.
The muscular system controls every movement of our body. Muscles are built from tiny fibers that contract and relax. Tendons link muscles to bones, creating movement and joints. When muscles contract, they shorten and pull the bone. Muscles work in pairs. One contracts, while the other relaxes. From walking to lifting, muscles keep the body moving.
That's mean the skeletal skeleton cannot be moved without skeletal muscle. That's right. كما ذكر في كتابنا القرآن الكريم، بسم الله الرحمن الرحيم، لقد خلقنا الإنسان في أحسن تقويم ثم رددناه أسفل سافلين. First, I'm going to present the introduction. What are the skeletal muscle relaxants? Skeletal muscle relaxants are a prescription medication that reduce the muscle tone to treat two primary conditions to prepare for spasm using the antispasmodic like cyclobenzaprine and the chronic neurological spasticity using antispastic agent for condition like multiple sclerosis. They work either on the central nervous system or directly on the muscle cells, like dandrulan. Common side effect for all, mostly like drowsiness and dizziness and necessitate caution of use. Classification of skeletal muscle relaxant and the neuromuscular blocking agent, it's divided into two parts. First, it's a neuromuscular blocker divided in the non-depolarizing and depolarizing, like succinylcholine, non-depolarizing, long-acting duration, turocurarine, and the short action, it's bivacurarine. And the second one, second divide is spasmolytic. Chronic use is divided also into the CNS action, baclofen, diazepam, and tizanidine. And also for muscle action, direct action, dantrolene. The other divide apart is acute use like cyclobenzaprine. First classification about spasmolytic. Spasmolytic are skeletal muscle relaxant that reduce the involuntary muscle contraction. They act centrally by inhibiting the somatic motor neuron signaling or preferably by decreasing the calcium ion release from the sarcoplasmic reticulum. They are used for short term for the muscle spasm and the second for muscle skeletal pain and spasticity due to the upper motor neuron disorder. Because the most across all these drugs, the blood-brain barrier, that may causing the CNS depression is the common side effect, and some agent can cause dependence and withdrawal problem. Mechanism of action of this group. First, depression of polysynaptic reflex like cyclobenzaprine and methacarbamol. Second, enhancement of inhibitory neurotransmitters in the CNS GABA receptor, a drug like baclofen and diazepam. Third, alpha-2 adrenergic agonism as tizanidine. It's a mimic norepinephrine effect and inhibiting the release of excitatory neurotransmitter in the spinal cord. The fourth action, it's direct action on the muscle cells like dantrolene. It's a unique and as it works directly on the muscle cells to prevent contraction without affecting the neuronal signal. The most side effect we can find it for this group. It's drowsiness, sedation. This is the common side effect in this class. Dizziness, fatigue, dry mouth, headache, blood vision, hypotension, potential for dependence and abuse, especially for carciprodol and diazepam. Also, carciprodol is putting in the black box because causing severe sedation and also for hepatotoxicity, so we cannot continue it or limit use only for 2 to 3 weeks. This code please scan and tell me the answer.
Okay. White screen.
You can back up.
Chronic use for this group also, it's the key of a drug, it's baclofen, diazepam, and tizanidine. The CNS action for baclofen, it's acted on the GABA B agonist receptor that inhibit the reflex at the spinal cord level, often administered via the intrathecal pump for severe spasticity. Muscle action, that means direct action on the muscle cells. Dantrolene is a direct acting skeletal muscle relaxant that work preferably at the level of the muscle cell itself. So the common condition, like before we mentioned, it's multiple sclerosis. We can prescribe, and also for cerebral palsy, spinal cord injury, and stroke. Now for the acute use antispasmodic centrally acting. The centrally acting antispasmodic are medication, it works on the CNS, the brain, and the spinal cord. To reduce the muscle tone, tension, and the spasm mechanism of this group is they act centrally in the brain, and the brain is named to sedate and generally depress polysynaptic reflex pathway. Common condition: acute low back pain, muscle strain, torticollis, fibromyalgia. This is especially for the medicine cyclobenzaprine. Cyclobenzaprine is like it's a drug that's similar to the tricyclic antidepressant for treatment of muscle spasm associated with the acute painful musculoskeletal condition. And also cyclobenzaprine is highly sedating effect. Now I can make it. The mechanism is summarized here in this chart. Neuromuscular blocking agents is divided in depolarizing and non-depolarizing. Starting with the depolarizing, first drug is succinylcholine is taken as IV, and the so depolarizing neuromuscular blocking use the medicine to it bind and can activate nicotinic acetylcholine receptor, producing brief muscle twitches first. Fasciculation, and then prolonged paralysis by the keeping the muscle and end plate depolarized. The clinical use for this, because the has rapid onset, 30 to 60 seconds, and the brief duration for 4 to 10 minutes, make an ideal short procedure like rapid sequence intubation and acute laryngospasm management. Adverse effect is going to make a hyperkalemia, malignant hyperthermia, muscle pain, bradycardia or tachycardia, or arrhythmia. Any question?
Question?
Ever wondered how your muscles move? It's all thanks to the neuromuscular junction. The NMJ connects a motor neuron to a muscle fiber.
Here,
When a
acetylcholine
nerve
coming
signal
from the
arrives,
heart
it releases a chemical called acetylcholine
and
neurotransmitter.
release the
Acetylcholine
acetylcholine.
crosses the gap,
After this, the
binds to the
contraction
muscle,
of the muscle
causing it to
will be
contract.
conducted,
An enzyme
unless
breaks down acetylcholine,
stress
allowing the muscle to relax.
will appear and
That's the
destroy the
neuromuscular junction,
acetylcholine coming
the
from
magic behind your
presynaptic,
every move.
and
Subscribe for
at
more
that time
fascinating
the
science
contraction
insights.
of muscle will be relaxed. This code please scan. This is multiple question. You have to answer it and deposit it to my classroom. With continue, you will see check the ID classroom. The second part are a competitive antagonist of acetylcholine at the motor end plate causing paralysis. Mechanism of action of this part. First, competitive binding by the disaggregate molecule bind reversibly to the acetylcholine binding site on the receptor, nicotinic acetylcholine receptor. Receptor blocked, this binding preventing the neurotransmitter acetylcholine from attaching to the receptor itself. Preventation depolarization without acetylcholine binding. No end plate potential is generated at this point. Muscle paralysis will, what the meaning of muscle paralysis? Muscle paralysis, the muscle fiber member doesn't depolarize, blocking the signal from a muscle contraction and leading to flaccid paralysis. This group are used for this condition, facilitate endotracheal intubation, maintain surgical anesthesia, manage mechanical ventilation, improve surgical access. Examples range from the long-acting is atiumocurarine and to short-acting is mivicurium. The adverse effect of this group, some agent can cause a side effect like histamine release, cardiovascular changes like hypertension or tachycardia, and flushing. Why it's flushing?
Dilation in blood vessels. Dilation in blood vessels.
Dilation. That's right. Important consideration and warning. Short-term use, the antispasmodic for acute pain are typically prescribed for only 2 to 3 weeks. Why?
Addiction?
Addiction. This most side effect for addiction. Due to the lack of evidence for long-term efficacy and the risk dependence and sedation. Second, avoid alcohol and CNS depressant. Combining this drug with the alcohol, opioid, or benzodiazepine can lead the dangerous level of the sedation and respiratory depression. Withdrawal, appropriately stopping baclofen, especially intrathecal baclofen, can cause severe withdrawal syndrome, including hallucination, and also seizure. Tinazidine can also cause rebound hypertension and tachycardia. Hepatotoxicity, dantrolene, it's the most common causing hepatotoxicity at his risk. Serious liver toxicity requiring periodic liver function test. Driving and operating machinery, patients should be cautioned against these activities until they know how the medication affect them. Also, for a pregnancy and feed breasting women, most skeletal muscle relaxant are not recommended during pregnancy or breastfeeding. Why?
Cardiovascular placenta.
This is for yes, for placenta and for breastfeeding
Can be secreted in the
and before. This is a scenario, a case scenario. Please activate with me. A 45 years old woman with a multiple sclerosis presents with a painful muscle stiffness and spasm that interfere with the walking and sleep. Neurological examination shows upper motor neuron spasticity. Oral therapy has provided inadequate symptom control, and her physician is considering the medication that enhance inhibitory neurotransmission at the spinal cord level. Which of these 4 medicine we will choose? Doctor?
Baclofen.
Why?
Because it's GABA receptor agonist that will act on the spinal cord and inhibit excitatory neurotransmission.
Right. Baclofen It's GABA receptor agonists that act at the spinal cord to inhibit the excitatory neurotransmission, making it the first-line agent of spasticity due to the upper motor neuron disorders, such as multiple sclerosis and the spinal cord injury. It is especially effective for the chronic spasticity and may be administered orally or through intrathecal pump in severe cases. Why not the others is not good? What the mechanism of them? First one for the cyclobenzaprine. Okay, I will answer instead of you. Cyclobenzaprine best used for acute muscle skeletal spasm, not for chronic neurological spasticity. And the C-datolin, why? What the mechanism of action and why we not use it?
Okay, because it's centrally acting by inhibiting the release of the calcium.
Yes, you are right. Datolin acts preferably muscle on the muscle by inhibiting calcium ions released reversed for the malignant hyperthermia or refractory spasticity due to the hypotoxicity risk. And the third one?
third one البيتا كارديوهرمون بسبب انه the central acting one antidepressant alteration of the muscle pain and disappear in this pain.
Oh, that's right. The metacarbamol, centrally acting antispasmodic for acute, using for acute muscle spasm or pain, not for upper motor neuron spasticity.
Okay.
Okay, now I will ask you for multiple question as MCQ. Just I want to know about your information from the previous lectures about the neuromuscular blocking agent and skeletal muscle relaxant. First one, which neurotransmitter is released at the neuromuscular junction? You have four options: dopamine, acetylcholine, norepinephrine, serotonin. Yes, ma'am. Acetylcholine. Acetylcholine is bind to which receptor or skeletal muscle? Which one you think it's the correct? Muscarinic receptor, alpha-1 receptor, nicotinic receptor, or beta-2 receptor? Yeah? Nicotinic receptor. The motor end plate is located on the motor neuron terminal, sarcoplasmic reticulum, muscle fiber membrane, tubule. Which one do you think?
I think the choice is C. Correct.
Correct. The fourth question, what enzyme will break down acetylcholine in the synaptic cleft? The oxidase or acetylcholinesterase, ATPase, tyrosine hydroxylase.
Acetylcholinesterase.
Yes, you are right. Which ion movement directly trigger muscle fiber depolarization at the neuromuscular junction? It's a potassium leaving the cell, chloride entering the cell, sodium entering the cell, or calcium leaving the cell. Yeah.
Sodium entering the cell.
C is sodium entering the cell. Thank you very much for your cooperation.
زين فد مناقشة يعني
هذا مو هذا انت بس جاوبيني شوفي على هاي اللي نزلت.
انا نسيت ليش سي مو دي.
مو سي اي ليش سي او دي او
زين
هذا؟
احكي لنا عن جماعة الأنس وشلون يصير عندهم ادكشن. هذا يصير شلون يصير؟
رجع الإجوبة الصحيحة.
هذا يصير
حتى
قولي
تكون
عندكم سؤال؟
اي بس بعد المقلوب لا لو نبقى
هو
بالقلوب.
دكتور المحاضرة على الانالجيزك؟
لا سكريتال مسار ريلاكسنت اليوم مسار بلوكينج ايجنت.
لاني
مصر
صار
إيه،
اذا ازيدش على ستات كولينستريز اوكي. هو هذا الانسر بي.
انسر بي.
نسأل عن
لا خلينا نسوي هاي ادكشن شوي سولفينا عليها. بس دقيقة خلي نصور هسه.
اي
قولي أبو سؤال.
Any question you can ask me about this previous lecture about skeletal muscle relaxant and the neuromuscular junction blocking agent?
Regarding acetylcholinesterase,
Yeah.
how it will break down this acetylcholine instantly?
Acetylcholine it's already released from the presynaptic synaptic vacuoles and will be going to release to the postsynaptic junction. It will be released as acetylcholine from this vacuoles to the postsynaptic junction. And at this time, it will be released the acetylcholine in this between the junction. And we're going to destroy the acetylcholine itself, so at that time the relaxant will happen for the muscles.
Yeah, the same ending will give acetylcholine. Will give acetylcholinesterase.
Yes, at
The
the
same.
same time. Yeah. After sometimes, not the same time, after
After the stimulation
the
happens.
stimulation and jump to the receptor at the postsynaptics.
How much time it takes this action? Something بالانستيزيا ينطون يعكسون الكولينستريز بالانستيزيا ينطون الكولينستريز حتى
So muscle relaxant or so
يعاكس المصل ريلاكس.
ينطون كولينستريز.
اي
على مستوى المصل
يعكسون
relaxant.
المصل ريلاكس اللي صار.
هاي مرحلة الإفاقة حتى إنه هو يقدر يقوم بالبيشنت. Yes, you are right.
بعدين عند قصي ما حضرت المحاضرة. أسألك سؤال إنه شلون أختار المصل ريلاكسنت المناسب للحالة؟ للحالة معينة؟ أسألك سؤال؟ إيه. دكتور السؤال شلون اختار المصل ريلاكسنت اللي يناسب الحاله الموجوده عندي؟ مثلا اذا عندي مثلا تي ام جي سبازم شلون اقرر اختيار المصل ريلاكسنت المناسب؟
It depends on this condition. If that patient has some problem with the CNS, I cannot use this CNS directly acting on the CNS. Should be taking a muscle relaxant. That means the direct acting on muscle itself, and vice versa.
Okay, thank you.
The reference is coming from Lippincott and from Cleveland Clinic. The feedback, please send me your opinion about this lecture. Did you feel that is adequate information provided, all information you need, from excellent to poor, and was the lecture delivered in a clear and understandable way, from strongly agree to disagree, to the Google Classroom ID number, this one. And that form, the Google form for the test, it will be evaluated by the robot for you. And full details lecture of skeletal muscle relaxant and the neuromuscular blocking agent will be available on the Google site. Follow this link. You will find all the information you need. This analysis for my lecture, the SWOT analysis, also you can find it in my Google class. Thank you very much for joining my class and for your active participation.